There are, again, some controversies that you hear with explantation and capsulectomies. The first one is an en bloc capsulectomy. And en bloc terms go back to surgery from many years ago. It was a terminology that we used when you were cutting out a cancer. And the more dangerous, the more aggressive a cancer, like a melanoma or a sarcoma, you would sacrifice a chunk of normal tissue around that thing to make sure you got everything out without getting close to the cancer or whatever you were trying to take out of somebody. Those operations can be very destructive. You're losing healthy tissue. So en bloc with capsulectomies, it was popularized back in about the 1980s by a plastic surgeon in Atlanta, Georgia, that she said that she does en bloc capsulectomies for all her patients, and this is what doctors should be doing. It's pretty much stuck. Unfortunately, nobody's been able to do any good studies as to how patients improved after surgery if they've had an en bloc capsulectomy versus a regular capsulectomy versus a partial. That's some of the ongoing studies which are happening right now. From my standpoint, I do a total capsulectomy because I consider that there's a problem with the implant, and you want to obviously get the implant out, but any tissue that's related to that implant to remove also. It's very difficult to do an en bloc capsulectomy. Somebody that has more capsular inflammation, a bad capsular contracture, the capsules are usually thicker. Patients that have had their implants put above their pectoralis muscle versus below the muscle, there's that extra buffer layer of tissue. So those patients, potentially you can do an en bloc capsulectomy. But in the vast majority of the patients that have their implants sitting on the chest wall, you have an implant sitting on top of ribs and a very thin layer of muscle in between the ribs. And to guarantee an en bloc capsulectomy, that would mean cutting portions, if not, a whole bunch of the ribs out, doing a resection of a chest wall, then having to reconstruct it. A fairly morbid operation that would probably leave patients permanently impaired from that surgery. So for something that's not a cancer, trying to do an en bloc and sacrificing ribs does not make sense at all. The other problem technically is most people have a very thin capsule. It's a very pliable, soft capsule. A lot of patients have capsules that are stretched out, and when you're trying to dissect a thin piece of tissue like a piece of saran wrap off a solid object like a rib and you're pulling it, it's going to tear on you. And as soon as you tear a capsule, technically that's not an en bloc capsulectomy. Doing a complete total capsulectomy, or some people have termed precise capsulectomy, basically removing the capsule in its entirety, that is straightforward and easy to do. And that's what I do in the bulk of my patients. Most patients, you can get the capsule out in one sheet with some tears in it. There are some patients, the capsules are very inflamed and you're just basically picking it out in a piecemeal fashion. Fortunately, the capsule itself is very distinct and different looking than normal tissues. So if you leave any capsule behind, it's obvious that you see that. You go back and take more of the capsule out. I have not so far run into a situation yet that I can't get the capsule out for technical reasons or safety reasons that I was afraid of injuring somebody. So yes, so the capsule is removed completely.